हेलो मेरा नाम डॉक्टर सैफ है एंड टुडे आई एम गोइंग टू स्पीक ऑन how to read 12 lead ECG. 12 lead ECG, whenever you get a strip in your hand, it's quite difficult. It's quite sometimes scary to see all those uh, funny waveforms on ECG paper. For a person who has not read it well or who has not understood the ECG well. So today my intention is to teach you the 12 lead ECG stepwise. But before that, I would like to tell you who was the person to whom we should be very grateful, who has brought the ECG machine into the world. The fellows in 1895, Dutch physician William Einthoven invented ECG, and that time it was called EKG, electrocardiogram in German. And this was a very big machine, and one has to put his left hand or left leg into a saline filled container to get an ECG, and it used to take a lot of time. And that time the ECG was called as simply galvanometer. Okay, the galvanometer is an instrument which is used to record the current, and ECG is nothing but it is voltage coming out of heart. So electrocardiogram essentially is a signature of electrical activity of the heart. And now you look at today's machines, which have become so advanced, so portable, okay, user friendly, touch screen, and can get you an ECG recording within minutes, within no time, and then you can interpret. So the task which is limited to you is just to read and to diagnose the findings and the life-threatening problems out of ECG. So as I told you, this is the heart, which is a muscular organ, and it contains an induction, what you call the electrical conduction. So you have to understand the electrical conduction system of the heart before you read an ECG. But from ECG, two most important informations one should be able to get within minutes is whether the patient is having arrhythmia, that is number one. The arrhythmia is a disturbance of the rhythm of the heart, how heart beats, okay, sequentially. There is a rhythm in the beating of heart, and that is called normal sinus rhythm. So when this normal sinus rhythm disturbed, this situation is called arrhythmia. And the second problem you should be able to diagnose in no time is ischemia or infarction, and that is nothing but the disturbance in the blood supply of the heart. So remember, heart is circulating or pumping the blood into whole of the body, essential for survival of a person. And for heart itself, some of the blood is required. Very small amount of blood is required for the heart nutrition or heart longevity and stability and vitality. So that is very important. And when that supply is cut to the heart, the situation arises which is called ischemia or infarction of the heart muscle, and that is very fatal. So the basic principles of ECG you should be able to see. There are a few deflections on the ECG paper, which is nothing, it is a graph paper, okay, and there are various boxes, small boxes and large boxes. So this is a ECG tracing. And how it is produced? It is produced because of electrical activity which is generated in SA node, that is sinoatrial node, in the right atrium, and then it starts or it conducts all the way from SA node to AV node, and from AV node it goes down further through bundle of His to the Purkinje fibers all over the ventricles. Okay, so this is how after this electrical activity which is generated in SA node, whole of the heart is charged, okay, is ready to contract, and after contraction there is a phase called relaxation. So both contraction and relaxation of the heart chambers is read on ECG paper in the form of few deflections, okay, positive waveforms and negative waveforms. So I'm going to tell you all those things. So normal waveform, which is shown over here in this slide, is actually in the lead 2. So there are various leads. I told you there are 12 standard leads. So I'm going to talk about that later. So these are the 12 leads system. Whenever you get a 12 lead ECG, you will be able to see these many leads. So there is a left side of the paper and the right of the paper. Left side of the paper shows the limb leads and augmented leads. Okay, lead 1, 2, 3 and AVL, AVR and AVF. Like that you will be able to see sequentially. Okay, so limb lead are placed on the left. The recording from the limb leads are placed or there on the left side of the ECG paper. And on the right side of the ECG paper there are precordial leads or chest leads. Okay, so what is the significance of these leads? So these leads actually register whole heart activity in a three-dimensional way. So limb leads register the electrical activity or voltage of the heart in a coronal plane or longitudinal plane, and whereas the precordial or chest leads register the voltage, the potential difference from the muscles of heart or cardiac muscles in a transverse fashion. Okay, so I'm going to elaborate on that a little bit. So these are three, so there is a inverted triangle which is called Enthoven triangle, named after the inventor of the ECG, William Enthoven. So this Enthoven triangle actually is a hypothetical triangle. This in its center the heart is placed. Okay, so there are three leads: lead 1 that is on the left side, lead 2 that is on the left foot, and lead 3 in the right foot. Okay, then there is AVL, which is between which is a line connecting center to the point of the triangle. Okay, like this: AVL, AVF and AVR. So AVL and lead 1 is going to record the electrical activity from the left side of the heart. Lead 2, 3 and AVF is going to record electrical activity from the inferior surface of the heart, and lead AVR is going to record the potential difference or electrical voltage activity from the right side of the heart. So whenever you see the deflection, the positive deflection in these leads, you remember that the electrical activity is coming from that region. Okay, for example, if in lead 2, when you see the positive P wave, it means that the electrical activity is coming from the atrium. Okay, and whenever you see the QRS complex problems very ST elevation in the lead 2, 3 and AVF, then it means that it is coming from the inferior wall, and inferior wall is damaged. Okay, so what are the precordial leads? So as I told you, these leads are placed before heart in the horizontal plane or transverse plane. So precordial leads record or register the potential difference in a transverse plane. So whatever electrical vectors which are coming out of heart in a transverse plane will be registered in the precordial leads. So there are 6 precordial leads starting from V1, V2, V3, V4, V5, V6. So V1 to V6, and they are placed in a very specific manner. So I'm not going to tell you that, but the more importantly I would like to tell you that in V1 registers the potential difference from the right side of the heart, right ventricle specifically, and V2, 3, 4 in the interventricular septum, and lead V5, V6 the left ventricle. So that shows left ventricle activity. Okay, the goal of the ECG interpretation is the ability to determine whether the ECG waves and intervals are normal or pathological. So I'm going to tell you the basics of ECG here again. The P wave is always the first positive deflection in the ECG paper in lead 2. Okay, that is your first positive deflection. Whenever there is no P wave or absent P wave, that is pathological. Physiological is what? P wave will be positive deflection, the first positive deflection in the ECG trace. Then the first negative deflection is the Q wave. It's a small wave, okay. Then it is followed by very large R wave like this, and then again negative deflection. The second negative deflection is the S wave, which is smaller, okay. So this QRS, otherwise known as QRS complex. So QRS complex signifies the electrical activity from the ventricle, okay. P wave signifies the electrical activity or depolarization from the atria, okay. Then comes the T wave, isn't it? The T wave is again positive deflection, and that tells you about ventricular relaxation. Then sometimes after T wave you may also see the small wave that is called U wave, which is not seen usually, but whenever you see a large wave after T wave before P wave, the next ECG, then definitely this is U wave, and that means that you have to check the potassium. Potassium may be low in such cases, okay. So that is very important. The U wave may be seen in the hypokalemia. Then there are few segments and interval in ECG. This is the anatomy of ECG. So PR interval is the most important interval in an ECG tracing. The PR interval is what is starting from P wave and end of or starting from Q wave, okay. So that is your PR interval. So PR intervals tells you the atrioventricular delay. The delay or in the contraction between the contractions of atria and ventricle. So atria contracts first, that is P wave, and then ventricle contract, that is your QRS. So the delay happens, there is a small delay, that is very important, so that the atria can empty into the ventricle, okay. The ventricle has to be relaxed at that time. So that sometime it may be delayed, okay. If PR interval delayed, that means that there is block, okay. That I am going to tell you later. Then there is a QRS duration. The QRS duration is green color over here. See over here, this is QRS duration. That is also important to know, especially in case of few tachyarrhythmias. The QRS complex becomes wide or becomes narrow. So normal QRS complex is usually 0.08 to 0.12 second maximum, okay. And the PR interval, I didn't tell you, the PR interval is usually 0.12 to 0.20 second. One more thing I would like to tell you, that in the ECG graph, the vertical tracings, vertical tracings are the voltage. So voltage is measured vertically and time is measured horizontally, that is x-axis, okay. So one small box is equal to 0.04 second. Remember that always. One small box is equal to 0.04 second. But always read this speed of the ECG paper. Whenever you are using a small machine, you will be able to see the ECG speed. You can actually fix it. Suppose ECG speed is 25 millimeter per second, then only one small box will be equal to 0.04 second. Okay, so that is very important to know. So PR interval is 0.12 to 0.20 second. 0.12 second. How many small boxes? Yes, 3 small boxes. 0.20 second, how many small boxes? 5 small boxes, okay. So normal PR interval is 3 to 5 small boxes. Normal QRS interval is 2 to 2.5 or up to 3 small boxes, okay. So that you should always remember. Then there is another thing which is in pink here, that is RR interval. RR interval can be very useful to calculate the heart rate. Heart rate is calculated by RR interval. So you have to count the boxes between two successive RVs, and then you have to count. You have to apply a formula to calculate the heart rate. I will tell you later. And then there is a QT interval, that is in green color again. So starting from Q and end of T, that is QT interval. And that is again important clinically, because if it is prolonged, it means that patient may have some deficiency of calcium or magnesium or potassium also sometimes, okay. Then there are segments. So important segment over here is the ST segment. So remember ST segment always. To look at ST segment, whenever the ST segment is end of S wave, this is end of S wave and is starting from T wave. Okay, so that is your ST segment, and ST segment and ST interval is different. ST interval is, it includes T wave also. ST segment is just end of S wave and starting of T wave. So when this segment is usually isoelectric. Can you see, this is the line, isoelectric line in a x-axis. Okay, so whenever there is a deflection out of this line, either side, we call it elevation or depression. So ST elevation is elevation of ST segment from the isoelectric line. Sometimes we have this J point. So remember J point always. So J point is the S wave where S wave ends and ST segment start, that is called J point. So J point elevates in the ST elevation, the conditions of ST elevation. So I told you the significant segments and interval, and now let's see the most important slide of this presentation, how to read the ECG. So whenever you are going to read the ECG, look at the whole tracing, remember. So there are two things, rhythm disturbance and the ischemia and infarction. So rhythm disturbance, यानी कि अगर rhythm में disturbance हो रहा है, arrhythmia हो रहा है, so then where you are going to look at? You are going to look at lead 2. Remember that. Lead 2 is usually a long lead, okay? I mean, it will be whole tracing. So you see the whole lead 2. And whenever you want to look at the ST segment, so you look at the other leads. But most important is lead 5, lead V5. So V5 is precordial fifth lead. So that is the most sensitive lead for the left ventricular infarction. Okay, so that you will be able to see then the lead V5. So that is the most important lead for detection of ST elevation. So now there are steps of reading or interpreting the ECG: rhythm, rate, PR interval, QRS complex, ST segment, T wave, and finally interpret or diagnose whether the ECG is normal or abnormal. Whenever you say the abnormal ECG, then you have to tell why it is abnormal. What are the components of abnormality in ECG? So whether the rhythm is abnormal or rate is high or low, or PR interval is very prolonged or narrow, or QRS complex is broad or narrow, ST segment is elevated and depressed, or T wave is inverted or flat line. Like that, you should be able to tell when the ECG is abnormal. So let's begin. So rhythm. So one by one we will finish. So it is going to be very interesting for all of you. So be with me in this presentation. It is going to tell you, it's going to give you some knowledge about ECG interpretation, definitely. So this is the example. So can you tell me rhythm in this? So whenever you want to talk about rhythm and you want to see the rhythm in ECG paper, look at P wave, look at QRS complex. So P wave is always followed by QRS complex. So can you see P wave and QRS complex? Here P wave and QRS complex. Okay, so this is sinus rhythm. This is sinus rhythm. Whenever P wave is followed by QRS complex, that is your sinus rhythm. Okay, and also you can see over here the RR interval is equal. So use a caliper to see the RR interval. Okay, so RR interval here is equal to RR interval here in between these two R waves. It means that this is regular rhythm. Okay. Here in this ECG, can you see the ECG? Each QRS complex is followed by, is following the P wave. So P wave is before each QRS complex, isn't it? Can you see? So this is also a normal sinus rhythm ECG. Now look at this ECG. This is a little bit different. Yes or not? Yeah. So can you see the lead 2? This is the lead 2. The bottommost part of the ECG paper usually is manifesting the ECG, lead 2 ECG tracing. So can you see the RR interval which are varying? Yes, correct. So this is arrhythmia, correct? There is a RR interval which is varying. However, it is sinus arrhythmia. Why sinus? Because P wave is always followed by QRS complex in all individual ECG complex. Yes or not? Yeah. So this is sinus arrhythmia. Now again another ECG. So this is again a very different ECG. Can you look at here? The RR interval are varying. Yes. So look at this segment. So RR interval here and RR interval is narrow over here, then again it is prolonged. So this is varying RR interval or variation in the RR interval. So definitely this is going to be arrhythmia. Okay. Now can you look at the baseline of ECG? This is baseline. Okay. ECG isoelectric line. So this is a little bit wavy. Can you see? Yes, wavy baseline or wavy isoelectric line. And there is no P wave you could find over here. Very difficult to find the individual P wave. So can you tell me, this may be absent also. Sometimes it may be embedded in the QRS complex. So it is very peculiar situation, and this is called atrial fibrillation, where RR interval will be varying, number one, and number two, the wavy baseline or P wave will not be visible. So this is your atrial fibrillation. Usually atrial fibrillation is seen in old age people who have COPDs and who have some history of smoking. So in such patients, look at, the diagnosis is usually atrial fibrillation, and the pulse will be irregularly irregular. The pulse, whenever you look at a radial pulse, that will be irregularly irregular. So this is animation, GIF animation. So can you see what happens with atria? What happens to atria and atrial fibrillation? So it fibrillate like this, okay, because of so much of discharges happening in atria. So atria are wavy, are fibrillating, are contracting very fast, more than 250, more than 250, more than 350, like that. So this is very peculiar. Now look at this ECG. Can you see? Again, the waveforms, isoelectric lines are, baseline is very wavy, okay, like sawtooth, like a sawtooth, okay. So this is sawtooth pattern, and RR intervals are regular over here, okay, sometimes maybe irregular also. So this is a condition known as atrial flattered. Very rare. So for simplicity of understanding, arrhythmias, that is the rhythm disturbance, are classified into brady and tachyarrhythmias. Brady means less than 60 and tachy means more than 100 heart rate, ventricular rate. So this is, we are talking about the ventricular rate, okay, QRS complexes. So brady means lesser QRS complex per minute, and tachy means more than 100 QRS complexes in a minute, okay. So bradyarrhythmias are usually because of atrioventricular blocks or heart blocks, and sometimes also due to bundle branch block. So in the conduction system of the heart, I told you there is SO node, then AV node, and then there is a bundle of Hayes, and then there are Purkinje fibers, the bundle branches, okay, and then Purkinje fibers. So there are left bundle branch and right bundle branch. Left bundle branch is always bifurcated into the anterior and posterior fascicles. So bundle branch, right or left bundle branch, can cause sometimes bradyarrhythmia. Now look at a tachyarrhythmia, which is again classified into supraventricular tachycardia or ventricular tachycardia, depending upon where the tachyarrhythmia is generated. Okay, so in SVT, the impulse generation starts in the supraventricular area, that is your atria usually, or even AV node sometimes. And in ventricular tachycardia, the generation of impulses are taking place in the ventricles, one of the ventricles. Okay, so sometimes you may have heard the term ventricular ectopics, okay, ectopic beats. And that is because of extra systole is happening because of some ectopic foci of impulse generation in the ventricles. Okay, So SVT is quite common in subjects who are very anxious, who are young, who are smoking or drugs, sometimes who are some or other drugs may develop SVT. In the ICU, in emergency department also you may see SVT. SVT is very fast, more than 150. The heart rate will be more than 150. Okay, and the QRS complex will be very narrow, less than 2 small boxes. Whereas in ventricular tachycardia, the QRS complex is wide, okay, broad. So we have talked about rhythm. Now let's next important thing is the rate. How to determine the rate. So for that you have to use the caliper or a ruler, okay, and count the boxes on ECG graph paper. So there are two methods, method 1, method 2. So depending upon which box, small or large box you are using. So whenever you are using the counting the small box between 2 RR waves, then you have to divide it by 1500. Okay. So that will give you the heart rate. For example, in this example, so the small boxes, can you count? So there are a lot of small boxes. 1, 2, 3, 4. To about 20 small boxes. You can see over here 20 small boxes. 1500 upon 20 to 150 upon 2. So that is your 75. The heart rate in this first example is 75. When RR interval is just here in the third end of third box, then heart rate will be 100. If it is here, R interval here and in the next wave, okay, next box, end of next box, then heart rate will be 150. If it is just one box, large box, then heart rate will be 300. Like that, you can this distinction can be used in calculating the heart rate very fast in emergency. Now in this example, can you determine the heart? These are the large boxes. So you count between 2 RR interval 1, 2, 3, 4, 5, 6, 7. So 300 by 7. So what will be the heart rate in this? So it will be about 55 or 50. Or about 40. 45. So this is a bradycardia. Okay. So always remember the QRS complex rate is equal to the heart rate usually. Now next important step is the PR interval. So PR interval tells you AV delay, okay, and normally it is less than 0.20 second, up to 0.20 second. If it is prolonged, that means that it is more than 0.20 second, it means that there is a problem, and usually the problem is in the AV delay, and that is your first degree AV block. If it is narrow, then there may be the possibility of pre-excitation syndrome and heart rate may be higher, okay, and AV nodal this is called junctional rhythm, so higher or lower depending upon where it is generating supranodal or infranodal. So first degree AV block means that you have to look at the PR interval which is fixed and more than 0.20 second. In the second degree AV block, Mohd type 1, the PR interval progressively lengthens with each beat until it is completely blocked. Okay, so can you see over here in this example? So look at R and then another R is absent over here. Okay, and look at the PR interval. So PR interval in this first ECG tracing and the second ECG complex, it is a little bit prolonged, and third ECG. So you have to use the ruler to determine the PR interval, any interval. So PR interval is progressively lengthening, okay, here in this example, and suddenly you see only P wave, but there is no QRS complex. So QRS complex is missed over here, and it means that this is the second degree AV block because PR interval is progressively prolonging and followed by a drop in the beat. So that means this is a Mohd type 1 second degree AV block. Never forget this. Okay, and it is usually due to reversible conduction block at a level of AV node. That is pathology. Okay. Now second degree AV block. What happens in the second degree AV block? There is no progressive prolongation of PR interval. The PR interval will be fixed, constant, but suddenly you will see the QRS complex is not followed by P wave. So in this example, see, PR interval is constant and P wave is there, but there is no QRS complex. Suddenly it is missed. Okay, so this is a bad situation when the PR interval is fixed and suddenly there is no QRS complex after P wave. That is your second degree AV block, MOBIS type 2, may be dangerous because it can progress to complete block, and you have to think of pacemaker. You have to keep the pacemaker ready, because anytime you may see that more dangerous, the third degree AV block. So what is third degree AV block? The third degree AV block is the complete AV block. It means that there is no synchronization, no harmony, no connection between atria and ventricles. Okay, atria and ventricles are independent of each other. They contract in different rhythm. There is no relationship present. However, the PP and PR intervals will vary, and atria and ventricular rates are different. So one thing which is quite peculiar to third degree AV block is the severe bradycardia. The heart rate will be between 26 to 40, anywhere between 25 to 40. Okay, so you can count the boxes between RR interval and tell us. So the heart rate in this situation, in this example, is less than 60 definitely. Okay, so depending upon the where is the AV block, sometimes AV block may be above the AV node, here just above the AV node, and sometimes the block is just below the AV node. So whenever block is infranodal, the QRS complex will be broad, and when the block is above the AV node or supranodal, the QRS duration will be normal or narrow. Okay, and you can see over here the PR interval, there is no relationship, it is varying so much always. See, okay, but the RR interval will be constant. PP interval will be varying. Okay, so can you see over here? So there is no connection. So what is the problem with the third degree AV block? It is dangerous because the atria are not able to contribute to the ventricular filling. So resultantly, the output, the cardiac output is less. So the coronary perfusion will be compromised. Okay, already compromised, and the situation is quite scary, and definitely you have to use a pacemaker and later plan with cardiologist to put a permanent pacemaker. So look at this ECG. What do you see over here? There is ST elevation. Okay, and then severe bradycardia, and also there is no MP wave is there, but it is somewhere, it is near the QRS complex, and in some complexes it is just away from. So PR interval is varying so much, but RR interval is constant, and there is a inferior wall MI because in lead 2, 3 AVF the ST is elevated. So usually third degree AV block is seen in case of inferior wall MI, because in such situation RCA is blocked, and RCA is the coronary artery, that is right coronary artery, which gives maximum blood supply to the SA node and AV node. Okay, so this is acute inferior wall MI with third degree AV block. So we have completed our rhythm, rate and PR interval. Now next is the QRS complex. So I am going to stop my presentation over here, and we will talk about the further steps of ECG interpretation in the next video presentation. So please follow, and thank you so much.